start the next session.
All right. So thanks so much again, everyone. We are going to start our opening session really talking about the impact in cancer and COVID-19 and what the data is showing us from a variety of perspectives. So we're very excited to have Dr. Yuri Fesko joining us from Quest Diagnostics, going to be sharing some data related to different excuse me, are we good? Screening modalities. Emily Kienzle will be joining us from our statewide CPED program and the Women's Wellness Connection, sharing the impact on the services specific in Colorado for women's screening issues. And then I will be sharing some data based on our colorectal cancer screening work in Colorado, as well as some national data based on patient impact related to COVID as well. So I think we're ready to rock with Dr. Fesko as our first presenter. So, and I'm seeing some good shout outs in the chat. If you didn't have enough time to make all those connections, we will have times throughout the day, but please use those chat features for questions, connecting with your friends and new colleagues as well. So with that, Dr. Yuri, I will go ahead and have you go ahead and start us off.
No problem. Can you all hear me okay?
Great.
Good. Okay. So I was going to talk about during the height of the pandemic back in March. Obviously Quest is a large company and has a large pathology group that is affiliated with Quest called Ameripath and DermPath Diagnostics. So between them, there's about close to 650 pathologists across the country. And one of the things that was very eye-opening and intriguing to me was during the height of the pandemic, and it has continued, we had significant drops in the numbers of cancers that were being diagnosed. There was a tremendous drop-off in the numbers of patients that were having pathology performed that our Ameripath sites were seeing, and we were seeing this in real time. And so we started looking at what are the implications of this and what does it mean, and doing a deeper dive into some of this data. So this is just a gross overview. If you can go to the next slide, we'll go into a little bit more detail. So if you looked across all the cancer types, this is from March 1st to April 18th. There was a 46% decline in the cancer diagnosis. And, a lot of people are like, well, what does that sort of mean? And it goes across colorectal, it goes across lung, gastric, esophageal, breast. We also saw it in pancreatic, which I'll go into a little bit more detail. But the implications of that are very serious. A lot of these patients are early stage cancers that are being picked up via screening programs. So, particularly in the colorectal, a lot of these are colonoscopies that were being performed, and we were down nearly 50%. The concern with this is, these cancers don't go away. They're just not being picked up. And so as time progresses, you're getting people who are becoming more and more, the cancer is growing. Obviously cancer is a logarithmic growth. Some cancers are faster than others. One of the real concerns with this data was that we would start to see an increase in the numbers of advanced stage cancers that started to show up when screening sort of resumed and diagnosis started to pick up. And particularly a lot of these, colorectal, breast, prostate, etc. If you pick them up quite early, people do very well. But if you pick them up late, you're into a metastatic setting potentially where it's incurable and you're onto chemotherapy treatments sort of indefinitely to prolong somebody's life. And what are the implications of that? So next slide, please. So this is sort of data that we are currently getting ready to publish, and there's a little bit more that I didn't put in here that is coming out in publication. We looked at prostate, and we've also looked at breast in much more detail. We analyzed about 16 million PSA tests from January 2018 to August 2020, and what we saw was a deep decline in testing in the early months of the the COVID-19 pandemic. And then we saw a rebound in the June through August. But the interesting thing is that there was, if you look at the year in an annualized format, you're not making up for what was missed during the height of the pandemic. There's still a group of men in prostate cancer who are missed. And so this is true also. We looked at breast cancer. We also saw that the breast biopsies, and I don't have a slide on it, but I can tell you that we saw the same thing, which is that the breast biopsies decline during the pandemic and extend out into June. Then in July, we have a rebound, but we are not seeing a complete recovery. So if you looked on an annualized basis, you're still off by 30% or so. Next slide, please. So if you look, you will see just how dramatic the declines are versus the other years. And again, you know, prostate cancer is a little bit more complicated because not everybody who has an elevated PSA necessarily has prostate cancer, but you see this steep decline. And so next slide, please. What we looked at was, you know, what did this PSA decline mean? And to give you, there's a lot of data on this, but we've analyzed it and we found that men who were more likely to have a prostate biopsy that showed very high grade disease were the ones that were most likely to be biopsied in the March-April timeframe. So they were older, they tended to have very aggressive disease, they likely had symptoms that warranted them going into the office. What was missing was a lot of the what we call Gleason score 6, 7, and early 8s, and they tended to be in a younger category. The part that's a bit concerning about that, again, is Gleason score 6, okay, could undergo watchful waiting. But Gleason score 7, and as you start to get into 8s, they tend to be asymptomatic, but they require treatment. Otherwise, the rates of them going on to develop metastatic prostate cancer are quite high. The same thing was again seen in our breast cancer data, which was we have seen that the biopsies that were being performed were a very advanced stage disease, where there are clinical notes that says there was ulceration of the breast, there were, you know, patient had bloody discharge, something of that sort that prompted a biopsy. When we see the recovery, we are still seeing more advanced disease than we would like to see. And so that's sort of the points of the discussion. And as Dr. Kaufman and I dig more and more into a lot of these different cancer types, our sort of worst fears of, you know, hey, the only people who are really getting biopsy, particularly during the pandemic, the height of the lockdowns, and then extending into the summer, are people who have symptoms. And how do we sort of recover and make sure that those who really need to be screened or seen get in for care? I think this is my last slide. So I'm not sure that there is one more. So again, just showing the same type of thing where what you're seeing is, particularly if you see in March, April, the PSAs that were done, and these tended to correlate with people who went through biopsies, they had extremely high PSAs. So these are men that likely had symptoms and really warranted biopsy. We did screen out in this population people who are known to have metastatic disease and are undergoing like treatment-related PSA testing. So these are people without a known diagnosis. And again, it's showing you what we've been sort of fearing, which is the only ones who are really showing up are people who seem to be advanced stage, high PSA, and probably have symptoms that warranted them going to the physician. I think that is my last slide. And with that, I will open it. I don't know if you want me to open it up for any kind of questions or if you want to proceed further.
Thanks, Dr. Fresco. Let me just ask you one question as we transition to Emily's talk. I think the panel and really thinking about future steps and thinking about only the patients that are showing up that are symptomatic or the biopsies for those folks are really showing that correlation between those. In terms of what we're learning from this and for the future, what do you think the one big take-home message is about what strategies coalitions should be thinking about, or public health or medical providers? Like, what's your big takeaway from this in terms of a can-do for next steps?
I think what I've talked to the Colorado legislature, but I've also talked to a number of other states because they're seeing the same problem. It's requiring us to sort of think outside the box. And, I have a couple of very good friends from residency who are gastroenterologists, and I sort of talked to them about what does this all mean? And they were explaining that really during the height of the lockdowns, again, the only people going to the endoscopy suite were people who were bleeding because the hospital shut down all ambulatory screening programs, basically. A couple of my friends have both said that obviously you have to protect patients against COVID. And so there are increasing screening protocols, but that the volume that they can get through the endoscopy suites has been cut by probably close to 50%. And so as a medical community, we have to understand that, COVID's not going away. We have to deal with the issues that we have. We don't really want to expose high-risk populations to getting COVID in a medical setting. So we try to, put all the screening protocols up, but doing more home-based testing through maybe a telemedicine visit, PSA testing through a home, through a remote draw with counseling by a physician as to what it means, and then trying to enrich the population for people that we are seeing something there that needs to be dealt with. Now, breast cancer, obviously right now, mammography is the most important thing that we can do. There's not a blood test that really can tell you if there's a way to enrich for it. But again, there are things that we can do. And I've worked with some of my colleagues at Quest on the laboratory side to sort of say, okay, can we do, stool-based, fit-based testing, get these out through programs where people are doing stool-based testing. If it's positive, they've got to go in for a colonoscopy, and those people get bumped to the top of the line. If we are going to do a PSA, those people who have abnormal PSA or abnormal PHI, for those who know what it is, those people get bumped to the top of the list to have a prostate biopsy, so that we really take care of the population that's got to be screened at this point. I hope that answers your question. It was a little long, but I think it's an important point.
Yeah, I do too, and absolutely. And I think so much of the work of the coalition and folks on the phone are really thinking about how to bring up and amplify the lessons learned and where to move. So thank you so much. Emily Kienzle, are we ready to go?
Yeah.
Awesome.
So thanks, Dr. Fesco, for your presentation. As we were talking about this for the symposium, we were talking about, do we have any data similar to what Dr. Fesco presented for Colorado? Because most of our usual data, like cancer registry, that kind of thing, is delayed and isn't in real time. And so I offered that our program has some real-time data about the services we're paying for and some of the data entry our grantees are doing. So I offered to do a quick presentation on what we're seeing in our data. And just as a reminder, I'm the manager of the Women's Wellness Connection program here in Colorado, which is Colorado's breast and cervical cancer screening program. So I want to start with our outreach strategy. So this strategy is really about finding women in the community and providing them with direct assistance to help overcome their barriers and to access breast and cervical cancer screening at a healthcare facility. So the data show here is the volume of the outreach participants receiving the direct assistance by the month they were last contacted. So that's the month when the grantee either helped the women get in for screening at a facility or lost contact with her. The gray bars show data from 2019 for the outreach strategy, and the blue bars show 2020. And you can quickly see the impact of COVID starting in March and continuing through the rest of 2020 as this strategy has been impacted, especially by being able to go out in the community. This is really about talking to people in person, going to community events, going, really meeting people in person, and then assisting them to overcome their barriers. And so this has really been hard to navigate in the world of COVID, where we're limiting interactions, limiting in-person events, those kinds of things. So you can see the impact. Next slide, please. So this is a similar graph for our health navigation and clinical services strategy, which is about the provision of and navigation to direct screening and diagnostic services by a healthcare facility. So this shows the number of women completing services per month. So you can see the big dip, very similar to what Dr. Fesco showed, starting in March and hitting a low in May. And while the services have trended back upwards, they're not anywhere near what they were in 2019. And they're definitely, like Dr. Fesco said, not making up for what was missed. And the other thing is our program is about serving low income women. And so we're also not seeing a big jump in number of screenings because people have lost jobs or lost their insurance and are now eligible and needing the services. So just wanted to make one quick note about this data because it's a little bit weird. Those end of year and August bars, generally we do our bill runs, which is what this is based on the 15th of each month, except at the end of June, we do another one on June 30th. So that really reflects like 2 weeks of data. And then we wait until August 15th to do another one. So August is more like 6 weeks of data. So that's kind of why those are weird. Next slide. So one of the things that Andy, Dr. Fesco, and I talked about when we were preparing for this is wondering how our demographics of the population served might have changed this year compared to last year. So I did a quick look of our demographics for the first 4 months of our fiscal year this year compared to the first 4 months last year. There wasn't a lot of changes, but one of the biggest differences was this increase in insurance with clients with no insurance. It increased by 11 percentage points between 2020 and 2019, and decrease in Medicaid clients, which decreased by 9%. Next slide. There was a little bit of a difference on the age. There was a 4% decrease in the 21 to 39 age group, but a slight increase in the 45 to 49 and 50 to 54 groups. Next one. There were no big changes in the race and ethnicity breakdown for the program, though there was a 3% increase in the white Hispanic population. And then we saw no change at all in the breakdown of federal poverty level. So that's my quick data. I will pass it along to Andy to share both local and national.
Great. And Emily, I think like you, within the Colorado Colorectal Screening Program and some of our state level programs, we did see dips, and we'll talk about that in a minute. But Emily, let me ask you to this, like when we're thinking about strategies and where we're going next and what's lessons learned, what do you think the big one takeaway for statewide screening for breast and cervical cancer based on this experience? What's the big take home message for you all?
I think one thing we're focusing on is communicating that it's important to still get your screenings, that's an important activity even in a pandemic, and that healthcare facilities are taking appropriate precautions to protect people from COVID. They're spacing out appointments, they're doing more cleaning, they're wearing PPE, that kind of thing, and really communicating that importance to not only cancer screenings, but you know, all preventive health care, that is important to keep up with those things, and those are appointments that are important to maintain.
Great. Good deal. Okay, well, thank you so much. And I'll round out our panel. So thanks so much. I'm going to again share some data that's relevant to Colorado, and then ultimately some data that's from the patient perspective and provider's perspective based on some work with Fight Colorectal Cancer and some data from other national agencies as well. So I'm Andy. I think I've met most of you or many of you. I am the Director of the Colorado Cancer Screening Program for Patient Navigation, and then the chair of the Colorado Cancer Coalition. So next slide. So I think what Yuri and Emily have both talked about is also with this pin-up demand, we're really looking at the number of people who aren't being screened, and then you really look at what that delay over the last 6 months had meant. And I think Ned Sharpless probably put out one of the most provocative statements around what this means, and that we're really looking at probably even conservative estimates, say over 10,000 more breast and colorectal cancer deaths in the next 10 years. And so again, I think these are conservative estimates that if we even look at this period of time, that if we don't make up those gains, and then you're thinking about moving to the future, what we're really looking at. So this is it was something we have to be taking very seriously in terms of the delay. And I think one of the things that I've shared with people on occasion is, this is a horrible thing that happened, this is awful, but it's interesting because I've actually seen, I think, more public health interest in screening than we have seen probably in any other period or within my career. So I'm very glad to see that our public health, medical, as well as our policy community is seeing this as an issue so that we can make good movement. So thank you for all the leaders out there who are really standing behind the prevention and control message, because it's going to be something that's going to have to really wager on as we move forward. Next slide. So one of the things that I want to share is really the perspectives from the field in Colorado, relevant to some of the points that Emily mentioned. What I would say is right now, and we'll share a little bit of the data from CCSP, that ultimately we are hearing from navigators, from our field teams and the like, that we had a lull. There was a lot of scare around the contraction of COVID, what it meant for patients, really weighing that acute needs, screening needs and the like. And this is something that we're going to have to continue to manage. For things like colonoscopy, really having pre-COVID testing and then actually going in for the exam itself and the prep and the like, there can be a lot of barriers. It's more for a medical team to manage. Patients on an individual level have very grave concerns about what's happening with their health and the health of their family, and really weighing that balance. So I think that's really come up in Dr. Fesco's comments, as well as what Emily had mentioned. And I think it's something we're really going to have to continue from messaging around public health strategy about how we manage the risk and benefit based on healthcare and particularly screening needs. Next slide. So I think this graph is very similar to what Emily showed, that we definitely see that lull. We are comparing also for our statewide colorectal screening component of our program. We start to look at a comparative of 2019 in blue and 2020 in orange. And it's very similar, where we see that starting to drop in March. By April, pretty much hit bottom. May starting to do a little bit more work, and then June, July. And then even into August, though, we're really excited because I think many of our navigators and our teams have seen the benefit of, once the elective procedure ban was lifted, really people got to work straight away to make sure that we're really engaging our patients as well as our teams in really the preventive screening nature. So as much as we see, I think, some real dire issues related to the April and May, and knowing the consequences of those screenings not happening at the same rate, what I will say is that I have been very excited that our programs have continued through August, September, and into October to maintain similar rates for screening for the program that we had in similar years. But what I would also say is, I think part of the take-home message, and Jamie Stutz and others, and even with our funder, the CCPD program, in our discussions, we've had a discussion about, there are networks of systems that seem to do a little bit better in terms of helping manage, but some of our rural communities, smaller communities, have really had a tough time maintaining the screening balance and the balance of care. And so we really need to, I think, put some additional support and really continue to eagle eye which communities are really low in screening and feeling that disparity. So I think, like Emily, we are seeing our demographics very similar to years prior, where that balance of making sure that we're meeting the needs of the medically underserved is starting to shine through in August, September, with these rates again moving up. But again, we do also see that our rural communities and communities of color particularly need some additional support in terms of making sure that we achieve the adequate screening rates. Next slide. So I'm going to share just a little bit of data that came out of an effort that I helped participate with Fight Colorectal Cancer. And I think this one's a little different in that we're sharing some of the patient perspective and data from the field. Next slide. And I think what I wanted to share specific is that I think there's a lot of lessons learned about where we're going and what we need to be thinking about moving ahead. I'm going to share some data that was ascertained through April, middle of April to the early part of May, which was, I think, the really acute period of when COVID was hitting and we were seeing shelter in place and the like. And the respondents of this national survey for the full data collection, it was about over 200, close to 250 individuals. And really what we're really looking at is what were the patient perspective, and about, I think 70% of the folks participating in the survey were ultimately patients. But really, at that point, a number of people had not had signs or symptoms. We had looked at folks who've been able to achieve testing, getting testing, and really what that meant. So although, at the point, and, we'll see these numbers grow, the number of folks who actually have not had signs or symptoms still remain quite high. But as we look through this data, we'll think about ultimately the management of anxiety and the impact of what that might mean for health is something to be considered as well. Through this effort, there were also a number of focus group and interview and key informant interviews that were collected. So we'll see some of that data moving ahead. But I think it's really important for us as a cancer community to also really understand that impact of patients and what it might mean for some larger strategies as well as individualized care. Next slide. So ultimately, at that point, I think the American Cancer Society, the ACS CAN was doing a great job. They found that about this period of time that about 50% of patients reported some impact on their health. And then in this survey, I think it also balanced that same perspective that ultimately almost 75% of the folks were seeing changes in in-person visits, changes in imaging. The supportive care needs were about 25% saw a different in change in how that was delivered, as well as active treatment, and then also even with clinical trial impact. So I think what we were hearing from folks is that they weren't sure when really things happened and hit what it meant for us in the United States. But as this pandemic started to really move forward, the change in the types of care and way care was delivered really was starting to impact cancer patients. So again, most of these folks who are really participating were people who were survivors or in active treatment. Next slide. And if you look at the landscape of that screening and treatment, the data that really came through is that ultimately we're starting to see some big trends that I think Yuri and Emily also alluded to. But we also saw that the cancer screenings were down from down 86 to 94% in March and this period of time, which I think is consistent, which we see nationally as well as within our state. The NCI model that I shared from Dr. Ned Sharpless and team started to show that cancer mortality and incidence based on what we were missing in terms of screening. And 18% of newly diagnosed breast cancer patients had an advanced stage disease compared with 12%. So these are the sort of trends that I think we're starting to see. This data that we've heard so far supports that work. And then again, making that impact in patient and teams, I think we're starting to see that and then really think about strategies to move ahead. Next slide. So I think one of the things I really wanted to point out is also disparities for the medically underserved. And based on the work from Fight CRC as well as Komodo Health, who were working in a combined strategy, what we did notice in this survey and this work with over 250 cancer survivors and people who were in active treatment is that most of the time Medicare individuals reported that they didn't have quite as good communication with their healthcare team comparative to other people who had private insurance. They had difficulties affording basic supplies, so social determinants of health and really accessing supplies and basic needs. And really when we were really managing and thinking about their ability to manage and cope, in this group, there were far more people that were really talking about inability to stop worrying almost every day and feeling as if they were struggling and not doing well, again, compared to those with private insurance. People living in rural areas tended to be on Medicaid for this survey. They had far more disruption in active treatment for cancer care compared to those living in urban areas. Also felt like they were higher on the score of really thinking about management of anxiety, having greater concerns about maintaining supportive networks, and then needing far more social support than those also living in suburban and urban areas. So I think one of the things, of course, coming out of this discussion, again, is those targeted populations and what do we need to do for strategies to really think about access to care in the screening and the like. Move forward. Next slide. And then I think when we were really talking about that financial burden, which I think has been front and center, is that people who had lost their jobs were not really receiving the same quality care and keeping that communication with health team. And then the ACS report that was published found that nearly 40% of those that had COVID-19 had notable impact on their financial situation, affecting their ability to pay for healthcare. And I think what we heard from a number of folks is that in general, next slide, that overall that we were seeing a lot of this sort of issue around financial concern and what this meant for them. But what was interesting is I think in the whole skew of things and where everything fit in terms of that balance of anxiety and where people were with managing their own emotional health, what still played front and center was really concerns about contracting COVID, concerns about the family and the health of their family and about the future as well. So finances was definitely up there, but when we really think about balancing what was happening, health came front and center, as well as just concerns about the future, as well as where was our state and our national leadership in helping guide us moving ahead. So I think one of the most profound comments I heard from this survey and the work that we were hearing is people actually started to say that on some level, this was the first time since their actual cancer diagnosis that they really started worrying about actually dying. And so I think this is something that we'll have to continue to manage, is really that stress, anxiety amongst cancer survivors, as well as that management of risk for ascertaining medical services and screening and the like. Next slide. And top supports, which I think was interesting, people really were talking about their families, partners, family support, and then the good old Fido pets really playing that front and center. And I think what's important to remember is so many folks were actually shelter in place, doing the quarantine because they were immunocompromised, but that social network, even there was social distance, it still remains really imperative. And I think managing and really thinking about how that connectivity helps manage for folks in the future is something to really consider. Next slide. There was some perspective, and this is actually just being published, and there's a poster at GI ASCO being shared, but also during this period of time, there was some work with medical providers to ask really about that disruptions in care and really what were the providers' perceptions of patients. So again, I think it was front and center. A lot of folks were really worried about contracting COVID and what that meant in combination with their treatment and therapeutics and what that might mean for their overall health. The disruption in treatment, that was really front and center as we saw those changes starting to happen. And then the perception of ultimately providers is that the patients were also really worried, about half of them, about losing their job. So I think it's really interesting to really look at that. What are patients sharing as their perceived issues and the provider's perception of what patients are interested in? And I think we're going to have to continue to have these sort of dialogues to keep that perspective and a really patient-centric approach moving ahead. Next slide. And I think for considerations for flu season, and that came out of this work, and I think to that point that I've asked Emily and Yuri about what do we need to be thinking about moving ahead. We really at the front need to understand where your patients are coming from, and one approach will not work for every patient. Utilization of telehealth is still something I think Yuri had mentioned, Emily had mentioned as well. We really have to think about the place in cancer screening and care delivery. Weighing that benefit to risk ratio and having a good communication plan with patients is going to be imperative. And then as we are now into flu season, really thinking about PPE, remaining healthy. I think Emily talked about the practices in the field and adjusting office plans really based on what's happening, and being really pivot like we have been able to do is something that we need to continue to consider as well. Okay, well, I think that rounds out my time here. Let's go ahead, and I don't know, I've been presenting right now, so we'll go ahead and start working with some questions as we're moving through the discussion here. So I see one from Casey. With COVID, will we have to adjust to the level of our area at any given time? We're currently in a major rise in cases and at risk of being shut down again. So again, we may have another dip on the already lower screening number of screens. So I guess I would ask Yuri and Emily just to kind of get us going in terms of response to this piece from Casey, who's in High Plains in rural Colorado. So Casey, thanks for joining. But in terms of like really what we're up against right now, and we've seen some data about what the impact has been so far. Yuri, I guess, what do you think? If you have a crystal ball, what's going to happen and what we should do as a result? What are you thinking? And I think you might be on mute. Becky, can you hear me okay?
Yes, I can.
Okay. And while we're getting Yuri set up, Emily, do you have any specific response?
I know, well, yeah, I only have like speculation, even though I'm at CDPHE, I don't know the official, you know, latest and greatest. I know that people at CDPHE are aware, you know, we're aware of that impact on screening and on services, and are, you know, are doing what they can to make sure that healthcare services don't get shut down again. That's my speculation. You know, a lot of it originally was about the lack of PPE and the lack of, and just not really understanding what was happening with the infections in the beginning, and getting things under control. And I think someone commented, like, I do think we have learned a lot, and I'm hopeful that we'd be able to maintain, you know, a higher level of healthcare services, even through this current spike than what we did before. But that's, you know, I'm not privy to what all is happening.
Yeah,
Sorry,
and Emily,
I couldn't get it to unmute. I'm back. I apologize.
No worries.
For some reason, my controls froze. So I agree. I think we are better prepared than we were earlier this year to come up with a response. Again, I think it's going to be up to all of us to sort of think about the solutions and sometimes understand that what we traditionally did and what the ideal scenario would be, it isn't going to work right now. And so thinking through lots of different methods of doing things, you know, ideally, lots of people, we would love them to have colonoscopies. We need to really understand from our ambulatory folks what volume could they handle, and if they're not able to handle everything, given, you know, the improvements that we have in testing and stuff like that, if they still have limitations, hey, as a group, can we come up with alternate ways of doing this? Again, I think, you know, breast cancer still is probably the hardest to, you know, because it really requires mammography, and that there are still precautions that have to be taken, you know, testing platforms. The one thing that I will say is I think the FDA is pretty close to having some approvals for asymptomatic COVID screening that is more rapid, which could make screening protocols much easier to perform. Again, you know, the FDA is an independent entity, but I've heard that they're getting much closer to that.
yeah, thank you, Yuri. And I think that's definitely a good point about where that balance fits. And I know that Emily and Yuri were also sort of looking at that crystal ball of sort. I see Carlin giving some shout out to Casey, and then Jamie Stutz, I'm going to go ahead and have you come off mute because I know you had a couple of comments also about individualized care. So Jamie?
Yeah, I think this is also an opportunity to implement more person-centered approaches to screening and communication. Messaging to folks, to our participants in our programs, that, you know, what steps we've taken to protect them, because there's really two levels here. There's the level of us knowing what kind of steps to do, and then the second level is convincing participants that these are appropriate and safe procedures to come to allow safe and effective cancer screening. And so I think that messaging those kinds of activities, making sure that people have the same confidence in our screening program, that maybe we're even doing a better job of personalizing our approach to them and facilitating their screening experience, could actually build relationship rather than damage relationship in this time. And I want to go back to the other point you mentioned earlier about the rural and other access issues. I think our large hospital systems have infectious disease divisions and departments that have helped our screening programs develop procedures. But our rural facilities may not have as robust of an opportunity to interact with those types of professionals, and being able to put together tools and serve as consultants to make sure that our rural facilities have access to those precautionary and protective procedures, and is a very important part to not seeing the disproportionate burden of this shutdown affect even greater disparities in rural and underserved areas. That part is what's particularly scary to me.
Yeah, and I would agree. And like I said, in that conversations that we're having, even with our funder yesterday, about where we are seeing concentration within the state of ability to screen and not screen, there's definitely your comments ring true. Emily, have you noticed that with WWC at this time? Is that we're seeing some shifts in terms of who's able to really screen in the same level for priority, or for based on whatever's happening right now with these facilities?
I don't know that I've been able, or that we've really been able to get into the weeds at that level of seeing. I think that's, yeah, so I'm not sure that we've been able to dig into that level of detail.
Andy, one other question I would have to the group is, thought is, there's also, you presented a lot of data about the financial impacts, and being sure that we as a medical community are very sensitive to the fact that people may have been furloughed over the summer. They may have significant financial limitations to screening programs, and making sure that as providers, as healthcare community, that we are sensitive to that and explain to them that there are multiple options at different cost points to get the same job done. And pushing for coverage of screening, testing, where it is lower, no cost to the patient, because as a country, it's so important to get it done. Those are the barriers that are going to we have to think about, particularly in the current economic environment.
I absolutely agree. And I think one of the things that I know several of us working in the colon world we're really, when our navigators couldn't necessarily work in navigating directly, talking about chronic care management, the ability for FIT and FOBT testing, and really thinking about that piece as well. So I think these are huge. And to that point, Yuri, about even policy and financial measures, I know the Cancer Coalition and other partners, ACS are really also looking at those out of cost partner, or what that might mean for follow-up colonoscopies for people who end up with positive tests, and what that looks like. And these are huge considerations. And Casey, as much as your question was a comment, or your comment was a comment, I turned it into a question, because that's a question I had, and it's great, brought great fodder. So I'm going to stand behind your comment as a question. Thanks for bringing that up. Jill, I wanted to ask you, Jill Fricker, you made a comment too, and I wanted to open it up about the curiosity about how budget implications will further impact. So Jill, do you mind coming off mute and framing your question, and let's have a bit of discussion?
Sure. I mean more for, state budgets, organizational budgets, community-based organizations, all of us sort of providing the safety net or support. I know that we've faced certainly some big challenges, and I'm just curious to see how that will play out in months and years to come. Does that help, Andy?
Yes, and I just wish I had an answer, so I'm just
that's why I'm like, I'm curious. It wasn't, you know, it's just something I think we all need to be talking about, you know, maybe, I don't know the answer either.
Mhm. Yeah, and I know we have, I think Eric from ACS can and some others, and we can talk about fiscal impact. I would even just say, I mean, even the state of fiscal emergency that might have been posed last year that would have put all of Amendment $35, which are the, you know, some great funds that are putting out, that didn't come to fruition. But if it would have, I mean, we would have been in even worse dire straits than we are now. And
Yeah.
this next legislative session coming up, I think it is a valid concern, and how we're going to keep this moving, I think, is a question. I don't know. I'm going to open it up for people who have comments or thoughts, because I think this is a really, really strong case, and something I think the coalition and our advocacy and policy folks might need to really be looking into. Anybody want to comment?
Hey, Andy, since you mentioned my name and ACS Can, I mean, I think part of, what helped us keep the legislature from rating those Amendment $35 is that the crisis that we're in right now is a health crisis. So most of the legislature thought it's not a great idea to take money away from programs that are health related. Will that stick for the next year? Who knows? I mean, if the ballot measure that was asking to reduce income taxes ends up, did it totally pass now? Last time I checked, it was still a little too close. But if that passes as well, it will make things even more dire. While, just giving everybody a few more dollars back per year, but added up, that can be many jobs, many programs that the state will have to figure out where that money is going to come from.
Absolutely. And I think you've got some big kudos and agreement. And Carlin, I want to pick up on your comment, because I think Christy and Eric can talk a little bit about this. And Eric, I just got to tell you, your dog is adorable. I love him. He just did a really fat, big yawn, and it was adorable. So to my presentation about pets being a support, I'm just going to say, for all of us, I think pets are mental health, like amazingness, and seeing other pets. But I think the idea about, are we sharing these presentations and information with the Cancer Caucus? I think Yuri had presented this data. So Yuri, thanks for coming and sharing that perspective. I know Eric and RJ have done a great job of keeping this work front and center. I'm guessing Jill has had those connections. But Christy, I know that you might be multitasking right now, but do you, even that interplay with the Cancer Caucus and the coalition, do you want to share some of the things that have been happening?
Yeah. So I actually met Yuri through the Cancer Caucus meeting and was like, I need to bring this to the symposium. So that exactly has happened. So Sarah Swan and I talk often around topics to share with the Cancer Caucus. And so last year we shared around the lowering the colorectal cancer screening age to 45, and the Cancer Caucus was really interested in that. Thankfully, the USPSTF has now made that decision for us, and we'll talk about that later. But I definitely have open lines of communication with the Cancer Caucus so that we can put things, things we hear here in the coalition that I think the legislators should be aware of, we then take to those meetings. Anything else you want me to add there, Andy?
No, I think it's good. And I want to just also say that I think one of the big advocates that we have in this work, I mean, there's a number of legislators and champions, but I think Diane Primavera as our, as our lieutenant governor, and as a cancer survivor, and as a strong component who used to be affiliated with, the Coleman group, and with Jill and your team and the work. I think that carrying this message is really that idea of prevention. And I think, Jamie, to your point, also looking at specific communities where we're really going to see a harder time in really thinking about how do we share that and communicate this moving ahead is going to be something that we'll have to move forward, because I think the Ned Sharpless data just takes conservative figures for breast and colorectal, but there's lung cancer screening, and I know Debbie Dyer's on the line right now, and we've been focusing, and Jamie and others, around lung cancer screening. But, those are areas where we've also seen substantial dips, the prostate work that Yuri talked about. So when we look at that mortality rate that we could be seeing, it's going to be really crazy. Sorry, Casey, what were you going to say?
I was just going to add one more item that from the last Cancer Caucus meeting, access to screenings and health equity, making sure the right populations are getting in and we're evening up their screening rates were really high priority conversation on the last one. So we're hoping that the coalition can address that on the January agenda. So stay tuned to hear what the January caucus agenda will be.
Awesome. So Jeanette, I wonder if you would be willing to come off mute and share your question, and we can get some more faces and voices in the convo. So Jeanette, can you come off mute?
Sure. So my question and concerns we've had here, and it may be because we're part of a hospital versus a freestanding clinic that people may be more comfortable coming to versus the hospital, but we are seeing biopsies actually get canceled the day before. Women will call and cancel their biopsy. So they've already had a positive finding in their screening that requires follow-up. And then their fears are getting the worst of them, even with all the reassurances we're doing. So I wondered if that's data that's being tracked as well, and if anyone has any messaging that has been effective in stressing the importance of getting in for these follow-ups to the screening. So screening is just the first part, but we certainly don't want the positive findings to go sit.
And I'm going to defer to any of the providers. I know we have a couple of docs, nurses, NPs on the line to also share perspective.
I was going to add, we have not looked at our data in that way, and it's probably beyond my basic data analysis skills to do it, but it's something potentially we could look into for WWC. One thing I wanted to sort of emphasize is that I think one of the things we do have in place through WWC and CCSP is our navigators and our outreach workers, and those people being one tool in our what's going to have to be a very large arsenal to address this, but that this is something that I know our navigators and outreach workers are trying to help. It's different than they had to do a year ago, as far as now they're sort of navigating the fears of COVID and outreaching and trying to reduce that barrier. But I think that is a tool we have is tapping into those navigators and outreach workers to help help patients overcome some of those barriers and fears.
And Emily, I would add to that part of the thing that we've been talking a little bit about is sort of a bit of a play on motivational interviewing, but also with harm reduction strategies and trying to talk more. But it's going to have to be something that we continue to really think a bit about. And again, I want to just open it up to anyone else that have additional thoughts. And I think there's some great comments, Jamie, talking about
one thing I have seen, it's sort of across the country is there's a great deal of fear that patients have about being alone and having these sort of invasive procedures done. Because of the COVID situation, we've eliminated visitors. It's really only the person who's having the procedure done. As testing gets better and we are able to do more rapid testing, I think it's something that we have to, as a medical community, sort of evaluate and risks and benefits of what we're doing, particularly for outpatient procedures, because, this is a terrifying thing as a patient to go through. They have a lot of anxiety, and then telling them that their support system can't come just pushes it over the edge. And we have to be very diligent about that.
So I wanted to also comment about the navigator role as being so important. I think, for lung cancer screening in particular, our navigator is always confirming eligibility initially on the phone before a patient would even get started into the lung cancer screening process. And I think that is a real opportunity for them to find out what the patient is thinking, what kind of reassurance they might need. And when we resumed screening at National Jewish, we actually did a survey of patients, and it's been published in the American College of Radiology journal just in November. But basically, we found that patients, most of them were ready to come back for screening. They really did need reassurance. But I can tell you from firsthand experience, now that we've brought a lot of patients back to screening, the unfortunate thing that we're seeing more of, which I don't know how to address this because we do all the things we're supposed to do, we're seeing a much higher no-show rate. And patients are not calling to cancel, and they just, I think at the last minute, get cold feet and just don't want to come in. And so we're now circling back, calling every one of those patients, finding out, you know, why didn't you come in? What can we do to assist you or help you? So I think the special personal touch is absolutely key. I don't know what else to do, but ironically, from our standpoint, we were getting patients telling us they wanted to come in, and then they just cancel, or that they don't even cancel, they just don't show. So that was we had a 25% cancellation rate last month. We've never had that. Not cancellation rate, no show rate.
Yeah, no show, no call. Yeah. So one of the things I want to say is I think that as we're starting to move forward, around resources, I think Ali Bain shared that the American Cancer Society has some fantastic playbooks that they put forward. We'll try to share those. I think this is an area around behavioral health and really moving this work ahead and really thinking about doing shared strategies. I do want to plug, I think Christy's done a great job in partnership with WWC, CPED, CCSP, a number of community programs, trying to continue to have these types of conversations and thinking about shared strategies, lessons learned, and what do we need to do to really elevate the resources and conversation. There's another one coming up very soon. So I think that we're wrapping up right now, but that is also a fantastic forum for us to continue these discussions. And I do want to also just say, I think Carlin made a great point about also the number of providers who are working in facilities who are seeing the burnout, themselves going through a lot of distress and fear. I think even within our program, we've seen some great turnover just because people are really having a difficult time as care providers as well. So I think those are things that we've got to keep front and center. There's going to be some additional panels coming up for us to share some of the themes that came forward, but we will also share, Ben, I think a great forum again for those network meetings to talk a little bit about how are we thinking about shared resources and support and lessons learned to really help with that patient perspective, keep screening and treatment front and center, but not putting people in harm's way. So I want to say a huge thanks to Yuri as well as Emily and everybody. This has been a fantastic conversation to get us started out this morning. So thank you so much. And I think, Christy, I'll turn it back to you.
Yes, thank you all. What a great start to our day here. I love that everyone's asking questions and engaging. This is amazing. I hope everybody's feeling energized. Now we want to give you a 5-minute break to stretch, jump, do jumping jacks, grab a snack, go to the bathroom. I put some links in the chat where you can go look for more resources. So go visit the virtual exhibit hall, find someone to chat with, just go get 5 minutes to yourself, and then come back at 10 a.m. for Cody's policy and advocacy session, and it's always a huge hit. So please come back at 10. Right now, just go enjoy 5 minutes.